Okay.
Hello, everyone. Welcome back to my YouTube video channel. I am honored to have Dr. Bill Hand on my show today. Dr. Bill Hand is the orthodontist, have been practicing more than 50 years, and he have a very different approach and very interesting in knowledge and case study that he done with. He been lecture around the world internationally in the topic of airway and treating patients from 3 years old all the way to 103 years old. So Dr. Wilhan, I'm honored to have you on the show. I appreciate your time today. It's been hard. I tried to schedule you several times, but finally I got you on the
Okay.
day today. I really appreciate your time.
Happy to be here. And any way I can do to help you.
Dr. Han, would you share with us the journey? By the way, I just want to say real quick, the day that Dr. Han graduated from dental school, that's the time when I was born. So it's 1974, and it's been a number of years. And you can imagine I had 20 years of dentistry experience, and he got 50 years of dentistry experience. So uh, of course, with his experience and the time that he spent with his patient, there is so much thing that at a clinician you practice every 5 to 10 years and you might change your philosophy. But so Dr. Birhan, when did you start like seeing this something the trend that they treating focus on facial and airway aspect? When did you start?
Okay. I think it's important to understand that I was trained very traditionally in a way that is still being used to train orthodontists. And I was an avid student, started 50 years ago at the University of Minnesota last month, 50 years ago in June of 72. I was an ardent student. I read all of the orthodontic literature. I scanned the articles from 1972 back to the early 1900s. This was something I did on my own. The instructors at the program had no idea I ever did it, but I used to take the journals home and read them or scan them because I wanted to know the history of the profession. And so what I knew, and I was looking for all the science there was, what I concluded was that there's not a lot of science. There wasn't a lot of science, and there isn't a lot of science. And what you basically had was a good old boy network with strong personalities, which taught orthodontics, which was basically a how-to profession rather than why. If you look for the why, then you wouldn't understand why we're doing what we're doing. But I wasn't sophisticated enough as a student. I was happy just to learn how, because that's what I wanted to do. And so I went and practiced very traditional. I was actually asked to stay and teach, which I did for almost a year. But then I decided, teaching was not my thing and practice was what I wanted to do. And I moved to rural Vermont to get away from the cities and just practice and do what I was taught to do. And I did that. And I took out teeth in more than half of my cases because that's what I was taught to do. And it really got into the late 70s when there was a general dentist by the name of John Witzig teaching general dentists to do orthodontics. And he had more than 35 weekends a year. He had courses around North America teaching general dentists to do ortho. His premise was that orthodontists are wrecking faces and causing temporomandibular joint problems. And when I first saw his information, I was not happy. I thought, who is this clown who's teaching general dentists to do orthodontics? And I took 2 years of my life to learn how to do this. And in a 2-day weekend course, he's going to teach people to do this. But I had a couple of friends tell me I needed to go take his course, and I actually decided to do that. I also had lunch with my best friend and best referring dentist, who said to me, he paid for the lunch, by the way, and asked me to have lunch with him. He said, Bill, I've done some continuing education, and I've met orthodontists who don't take out teeth as often as you do and who treat earlier than you do. Why do you do what you do? I had a monstrous sympathetic nervous system reaction over that. Adrenaline shot through my body. I was terribly embarrassed. And I said, Michael, I do what I was taught to do. But I knew intuitively at that point that I simply had to change. And this was about November of 1981, and I started doing continuing education. I lived in rural Vermont, and the very first course I went to was right in the city where you are right now, well, in the Golden Gate Bridge behind you. I went to San Francisco for a course in November of 1981. And that never stopped. One course after another, after another, after another. And what I learned was that there were other ways, and I wanted to stop removing teeth. And I had no clue where it was all headed. And I lived in a town where, you know, a small town of 18,000 people in Vermont, where what you do gets home before you get home. In other words, everybody knows what you're doing. And if what you're doing is successful, you will be successful. If what you're doing is not so good, you might as well pack your bags and leave. So I tried new things and that I had never tried before. And fortunately, they worked. I stopped removing teeth, stopped retracting. At that point in my life, it was all about facial aesthetics. And I knew, all I knew was I knew that the faces I was producing were not great. And they often looked worse when I was done than when they started treatment. And I thought, I can't continue to do this. If someone's less attractive with their face back when I'm done, they're better off with no treatment. That's why I was motivated to do all the continuing education. The years went by and my practice got better and better, and general dentists in the area liked what I was doing. And from towns around me where there were orthodontists in those towns, they began to refer to me for people to drive more than an hour to come see me because they liked what I was doing. And the practice grew and it was fun and I was happy. But I was looking for answers because there still was no real science behind what I was doing. And I was looking for that scientific evidence. I could see that the faces looked better when I didn't take out teeth, but I didn't truly understand what was going on. I mean, I've been taught that there was a big genetic determination that caused us to have certain kinds of malocclusions develop, and yet no one ever proved that. No one ever showed any evidence to support it. That's just what you're taught. And in reality, there's really no genetic determination to this. And finally, about 1990, I met John Mew from London, England, who was going to be 94 years of age this September. I heard him speak in Newport Beach, California. I flew all the way out to see him. And then I went from there, that October, I went to London to learn from him. He didn't really have a formal course, but I went to his office and I saw what he was doing, and I was amazed at the faces he was producing, basically doing the exact opposite of what I've been taught to do. For instance, in a class 2 case, traditional orthodontics retracts the upper anterior teeth and assumes that they stick out, but they don't stick out. And interestingly, in the orthodontic literature, we have known this, and it's been published in the refereed literature in July of 1981. There's an article by James McNamara confirming that. So in treating patients like this, class 2 patients particularly, we develop the maxilla forward, 8 to 10 millimeters. We then develop the mandible forward. And what you're really trying to do is to correct rest oral posture. Most of our malocclusions, that anybody who has a malocclusion has poor rest oral posture. They don't have their teeth together. They don't have their tongue to the palate, and they don't necessarily have their lips together. They may even have their lips together, but they don't have their tongue to the palate. And so various kinds of malocclusions develop based on what specifically is going on. So the goal is to make everybody become a nasal breather and optimize their facial balance in the process. By the way, from your city, you have the person who has helped bring this to the fore for people all over the world. James Nestor's book, Breath, was published 2 years ago, was number 6 in the New York Times bestseller list, and is published in 32 languages.
Wow.
Now, in that book, he talks about the health benefits of nasal breathing. He also references John Mew very, very significantly. So my practice then changed completely, and I understood what was needed to be happening, and I got into the concept of developing the face forward. I now even treat in the primary dentition, age 3. The point here is what's happening for kids, and if you really understand this, and there's plenty of science behind it, you can read articles and in the referee literature by Ron Harper from UCLA, a PhD neurobiologist who documents brain damage in children when they have even one night of reduced oxygen saturation in their brains. And he deals with the MRIs and shows those areas of the brain which are damaged. And it'll affect motor control. You also have someone like Phil Cooper, who's an African-American dentist friend of mine in Savannah, Georgia, who's written a book stating why African-American kids can't read. It really doesn't have a thing to do with the color of their skin. It has to do with the fact that so many of them have sleep apnea issues and have brain damage, such that by the time they even go to school, they're not going to learn to be able to read well and really have normal lives. So when you really understand this, it becomes the whole tooth thing as a dentist becomes secondary, and you realize that what you should be doing is optimizing facial balance, which optimizes airway, and the dental profession needs to understand that we just don't understand it, the key to overall health. When you realize the airway paradigm and how every chronic disease is associated with poor breathing and sleep apnea. So that's in a nutshell where I am today with focusing on really trying to train other people to treat very early. I have a mentorship for that with focusing on treating under age 6. I also have a mentorship where I'm trying to train people to deal with patients over age 10, and with specifically how to reverse previous retraction, particularly reopening previous orthodontic extraction spaces for people. This is something that I've been doing since September of 1989. And I've had people from more than 30 states and several foreign countries come to see me for me to do this. I'm trying to train people everywhere they want to be trained, because I can refer them tons of patients, particularly from Asia. I know you're Asian, and Asian people today are having teeth extracted at a much higher rate than Caucasians are. There are reasons that that's happening, and it's very tragic, to be honest with you.
Wow, Dr. Heng, it's amazing. What a story, and I really appreciate that your time to go over the history why you really changed your philosophy of treatment. So let me ask you, let's say an orthodontist. By the way, I just want to ask you, do you train general dentists as well, or just only orthodontists?
I train mostly general dentists. I have a handful of orthodontists that I've trained. I'd love to train more orthodontists.
Yes.
General dentists who come to see me generally come for the following reason. They've had their children followed in an orthodontic practice, and the orthodontist says, don't do anything, don't do anything, don't do anything. Finally, all the permanent teeth are in. And then the orthodontist says, well, we got to use a headgear, or we got to take out some teeth and straighten the teeth. And then the general dentist just rolls his or her eyes and says, excuse me, I can't do that. And then they go call a friend, another general dentist that they know who is doing orthodontics, and say, where do I learn how to do orthodontics? Because the general dentist has been in practice long enough to see what goes on after the extraction retraction has been done. So most of the people I train are general dentists, and many have children they want to treat because they do not want to have them treated traditionally. I train a number of pediatric dentists, and to be honest with you, the people who are on the front lines of what I call the airway war should be the pediatric dentists. They're the ones who have the behavioral expertise to treat the very young kids. And they are the ones who see them really young when treatment should really begin, long before the eruption of the first permanent tooth.
So I really appreciate this conversation, because when I heard about the topic, like you mentioned, like treating case that have extracted and then now you expanded. So I have two adult friends. They did have 4 bicuspid extraction, and I asked them, do you snore? They say yes. Do you wear something right now? Yes, I wear the the CPAP.
Yes.
So it's not just coincidence. This is like something that I see, and I that's why I believe that what you are doing is something that the world needs to know. That's why I try to reach out to you and have a conversation like this to inform the dentist population as well as the specialist population to fight for this pandemic type of treatment, where it affects not only short term but long term, for until when we get hypertension, then we have sleep apnea, called cardiovascular disease, that you mentioned before in your lecture. So in regard to the kid, Dr. Hans, what is the earliest age that you can treat the kid?
Well, the earlier the better. And to be honest, orthodontics alone, there should be something coming even before we are able to do orthodontics, because many of these children are at the time of birth, they're already behind the 8 ball. They're not developing well. In utero, they're not developing well. And a good friend of mine has documented this, looking at ultrasounds of babies in the womb. And so what you're dealing with is someone who's already starting out with problems, and you end up, and Christian Guilleminault, who passed away 3 years ago from Stanford, talked about how premature births, all those kids are going to be paddling upstream, and all of them are going to have sleep apnea issues, and they're going to struggle with that. So the idea is to do what you can do early on. Let's start out really, really early. First thing you can do is look for a tongue tie. And you say, well, what is that all about? Well, it has to do with proper nursing. And Brazil made it a law about a decade ago that every newborn be examined for tongue tie. And within the first year of that law being enacted, from what I have heard, they had about 47% of the children had some degree of tongue tie. And there's a gradation of that. But the reason for examining for this is that many of the babies can't even latch onto the nipple. And it's not only they're not getting the milk, which is better than any kind of formula, but they're not getting the proper exercise of the face to develop the face forward. So they're starting off not in a good position. So right away, breastfeeding needs to happen. Lactation consultants need to be used by women. And I see that breastfeeding went way down during the pandemic. Well, we got to reverse that, because we can't deal with the pandemic as you use it. And I agree with you, it is a pandemic far worse than the COVID pandemic of what's going on with the airway problems surrounding everybody in the world. So myofunctional therapy, if it can be done at a very early age, long before you even see the orthodontist, that's a great thing to try to establish nasal breathing. And there are a lot of mothers who are motivated to do that for their kids. And so you find myofunctional therapists who are good at that. But many times you can start expanding. And from my perspective, I treat kids age 3, starting at about age 3. I've not treated a 2-year-old, and I don't really look forward to it. 2-year-olds are a bit of a challenge, it's just behaviorally.
Yeah.
But 3-year-olds, and the real issue here is the mother going to be motivated and really help in the process, because the mom is ultimately the one that's going to be in charge. And I don't mean to minimize the input that a father has, but I'll be honest, the mother has more influence than the father ever is going to have. And particularly if a mother has had bicuspid teeth taken out and been retracted, they're highly motivated. So they'll be happy to have treatment starting at whatever age, because they will move mountains to have something better for them than they had themselves. I want to make another point before we get too much farther down the road here. I am not stating that every time someone has retractive treatment and bicuspid is removed that they are going to have problems. Some can tolerate it okay, many cannot. And the point here is, and I make this point very strongly, I have put together a lecture slide that I've used many times. And that slide says, after I've shown a case where I was reopening bicuspid extraction spaces only in the maxilla for a 40-some-year-old woman, and I have a sleep report signed by a physician that states this woman gained 10 pounds from her first sleep study to the one that she was just done after I had reopened the spaces. And despite gaining 10 pounds, she completely eliminated her sleep apnea just after we had reopened her extraction spaces. Excuse me just a second. I then asked the audience, do you believe that it is possible to retract enough to cause sleep apnea? I actually asked this question at the Fairmont Hotel several years ago in San Francisco to a group, about 400 people in the room. And I said, is there anyone in this room who does not believe it is possible to retract enough to cause sleep apnea? Not one hand went up. And I said, please, let's have a show of hands. Nobody raised their hand. And then I stated, I do not see one hand in this room. Therefore, I'm concluding that you all agree with that. The next thing pardon me just a second, I got to get a drink of water. I'll be right back.
So, so guys, you are watching Dr. Bill Hand specialize in face focus orthodontist and dental facial orthopedics. So Dr. Bill Hand is focusing on the overall facial aspect of a patient. He doesn't focus on only just teeth. Very interesting topic. So Dr. Bill, please continue.
Okay, thank you. Sorry, I was coughing there. I just had my first cold I'm dealing with it for 3.5 years. I haven't had a cold for 3.5 years.
Yes.
You get 2 colds a year, but I tape my mouth for sleeping and have for over a decade. And if I ever even take a nap, I will tape my mouth on an airplane, for instance. Earlier this week, last Sunday night, I fell asleep for probably 15 minutes after I had a meal. I was sitting on the couch, and that night I had a sore throat, literally because of my mouth breathing. So I am so committed to and so I was really unhappy with myself because I hadn't had a cold in 3.5 years. And so here I am recovering from that. Sorry for the coughing spell. Back to my lecture. My lecture was this. So the next question, after everyone had agreed that you could retract enough, that it was possible to retract enough to cause sleep apnea, I said, okay, how much can you retract before you cause sleep apnea? Does anybody know? And no one said they did. And I said, I don't either. I said, I have no way of knowing that. The next question is, then, if you don't know how much retraction you can safely do before it becomes unsafe and you might cause somebody to snore, which, by the way, snoring alone is correlated with plaque formation in the carotid arteries. That came from Henry Ford Hospital in Detroit, Michigan, about 6 or 7 years ago. It's on Yahoo for anyone who wants to go find it out. If you don't know where safe retraction becomes unsafe retraction, how can you ethically and morally retract even minutely? And I leave that for the profession to answer. I believe it's an important question that needs to be answered. And I'm not going to retract. I will not retract because I don't know where that is. And I've reopened spaces for people and barely moved their teeth forward and had them come in and say, my spouse says, I'm not snoring anymore. And I say, you're kidding me. I barely moved your teeth. And no, I'm not. My spouse says I'm not snoring. And I'm not about to say, well, your spouse is nuts. I just say, who knows more about this than they do?
Right.
We're dealing with a very interesting thing here, and we're dealing with what needs to be a paradigm shift. By the way, how many on your podcast here are aware that the American Dental Association 5 years ago this September mandated that every dentist screen for airway issues? Most dentists don't know that.
Right. Most people don't know that, and they don't do that either.
No, exactly. So you asked me some more questions here.
Yes. So so let's say now, if you for the way you approach now, Dr. Hank, would it be depend on the ethnicity of the patient, how you treat it, or you would treat the same way with Caucasian, Asian, African American, all the same way, or a little bit different?
Every case is different, to be sure.
Yeah.
But the reality is there's very little difference between the races in terms of what's going on for them. Let's talk about that, however. I mean, the point here is you do whatever is appropriate. You look at the patient history, the birth, what happened during the birth. Did the child, was it a normal birth? Was it premature? Did the mother breastfeed? If so, how long? Did they use a pacifier? Has there been problems with someone recommending tubes in the ears? Has the child been on antibiotics? These are all issues that really relate to mouth breathing and ENT, ear, nose, and throat issues. Has an ENT specialist been consulted? Someone recommended taking out tonsils and or adenoids? So this is all very important. But when you look at different people, in reality, I mean, and there's a Daniel Lieberman, who's a Harvard anthropologist, PhD anthropologist at Harvard, says we are our faces, he has a book called The Evolution of the Human Head. Our faces are different from our ancestors because our faces are back relative to our ancestors. John Remmers, who's a Harvard-trained MD and a sleep physician, well known in the sleep industry, he says we wouldn't have sleep apnea if our faces were forward where our ancestors were. So what we're trying to do, no matter the race, is to develop the face forward. Now, the interesting thing is, and I'll talk about why Asians are at more risk for all these issues. Number one, the Asian cranial base from basion to nasion is generally a little bit shorter. So the head is shorter in the anterior-posterior dimension. But the Asian has to get every bit as much oxygen into their body as anybody else. And so that airway has to be placed in the head in a smaller space. Okay. Now, the other thing that goes on here really goes back to the 1940s, when in the orthodontic profession, the aesthetic line was popularized. That's a line from the nose to the chin. And this was used to say, oh, your face is too full. Draw a line from the nose to the chin, and ideally the upper lip should be back 4 millimeters and the lower lip back 2. Well, maybe that's appropriate for Caucasians, maybe. I mean, that's debatable. But it definitely is not appropriate for Asians, nor is it for anyone of African American ancestry. Let me explain to you why. Because an Asian nose or an African American nose are shorter than a Caucasian nose. And so depending upon the ethnicity, what Asian group you're dealing with, those noses can be very, very short or not that much different than a Caucasian nose. The point is the lips are going to look fuller than on a Caucasian. Then of course, this whole argument ignores the fact that the chin in most of our cases now, in most people in industrial societies, our chins are massively recessed from where they used to be. So if you draw a line from a short nose to a recessed chin, everybody in the world is going to have a face that's too full. And so teeth have to be taken out. And sadly, I've never been to Seoul, Korea, but I understand that there are advertisements in the subway system there about various kinds of ways to flatten your face and all. And I also understand that there are 75% of the people that are getting orthodontics or in the Asian countries are getting teeth removed for it. I don't know if that's true or not. I've just heard it from someone from a source that I view as credible, from a survey. Whether it's true or not, I don't want to say that. All I can say is teeth don't need to be removed and shouldn't be removed. And I treat Asians without removing teeth, and I've treated an incredible amount of crowding and really don't make the face too full. My feeling is you better accept a fuller face and a bigger airway than a flatter face and a reduced airway that makes you have a problem. And I get emails literally many days a week. I'll wake up to an email from somewhere in the world, particularly from Asia, saying, gee, I've had such and such done and I can't breathe and I can't sleep. I just did a long distance consultation this morning with a 33-year-old man from Wisconsin who had that very issue. And before I finished, I said, you need a sleep study done. You must have a sleep study done, because here he is, he's falling asleep while he's watching TV, while he's reading, or even when he's driving. He talked about having to pull off the freeway and take a 20-minute nap in a rest area. A 33-year-old man should not be doing that. And so, he's going to come to see me for me to reopen the extraction spaces. And I make no promises that I'm going to resolve the problem. But all I know is it has worked in the past. So all ages, all races need to have forward development of the face. All races need to develop lip together posture. All races need to be nasal breathers. The interesting thing here is this isn't even new. It isn't new by any means. That back in the early 1900s, and I have references from the literature, this was being discussed, and there were dentists recommending treatment in the primary dentition. They were also, to expand the arches and create more space, they were also very vehement about nasal breathing and getting people to get their lips together. Public health book from New York from New York City, published in 1909, talks about this very issue. Going back into the 1800s, they recognized that many people in prisons and many, they called them degenerates. This is before the era of political correctness, or even idiot. They would use the term idiot. An idiot made normal by getting them to have be a nasal breather. I mean, this has all been out there for 100 years. The thing is, we as a society as a profession got away from treating them at that age, and it became a standard of care to just wait for all the teeth to come in and line up the teeth. And that's pretty much the way it is. The trouble is, by the time that happens and you have all the teeth in, the lion's share of the growth has occurred, and the maxilla's back, the mandible's back. You have many people with a nose that appears big but isn't, and they have no chin. And now you're going to line up the teeth. Well, it really makes no sense. So you have to be treating early.
So Dr. Hank, so in general, when you do an ortho case, do you do the CT scan for the airway right away at the first day?
I love to have the cone beam for that. It's terribly important. It helps us understand where the small areas are. And if we're dealing with young kids, I mean, we can laterally expand, and that's great. Everybody knows how to laterally expand, but most orthodontists, they'll only expand enough to correct a posterior crossbite. Since my own children were age 6 and 8 or so in the mid 1980s, they're now 46 and 44. I have been expanding both the maxilla and the mandible.
Wow.
Now, we've all been taught in orthodontics that you cannot expand the mandible. There's no midline suture. We all know that. We were taught that if you expand the mandible, you're going to push the teeth off the bone support and you're going to cause tooth loss. Well, I'm happy to say that doesn't happen. My own boys I did this for. They're 46 and 44. And one of their sons I did this for. He's 13, and we expanded his maxilla and mandible 10 millimeters. And I just visited him a week ago in Greenwich, Connecticut. And he's 13 now. He's never going to wear braces. He's happy. He's got all the room in the world for his teeth, and the teeth are lined up nicely. He's a nasal breather, and we treated him when he was like 7 with expansion. I actually didn't do it. I had a general dentist that I trained to do it an hour away in New York State, that my son and my daughter-in-law took him there to have this done. So the idea is we try to even avoid doing orthodontics. We want to do it early. The earlier you can do it, the better. It's really critical to do that. And the point here is that expansion of the mandible is possible. And I even do it in adults.
Wow.
I've been married for 51 years to the same woman. And I was told that I needed to take out 4 teeth for her literally 40 years ago this year. And the head of the orthodontic department who trained me told me that. And he said to take out 4 first bicuspid teeth. And I was going to take out 4 second bicuspid teeth, thinking it would affect her profile less. This was way back when I was just transitioning out of traditional treatment. And when he said to take out, and I wrote him a note, I said, I'm going to take out 4 second bicuspid teeth. I think it'll affect her profile less than if I take out first bicuspids. What do you think? He says, take out first bicuspids. Technically, it's easier and will make no difference on her profile. The best letter he could have ever sent me. Because when I read it, I knew he was wrong, and I decided I'm not taking out any teeth. She's going to be a guinea pig, and I'm going to align her teeth without any extractions. I did that. Later on, I violated another rule, because then I didn't expand laterally her cuspid width. Years later, I expanded her more with expanding the cuspids, because we were taught to use very narrow arch forms and never expand the cuspid width. Well, I expanded her like another 5 or 6 millimeters in the early 90s. And more recently, she'd begun snoring, and she asked me to expand her even more. And so in October, I put her back in braces for the 3rd time and took her out in February. She has about a 39, almost 40 millimeter intermolar width, and I expanded both of her arches. And no, I haven't pushed her teeth off the bone support. And that's the biggest fallacy. People are going to be taught that, and they're taught that with religious fervor. But you know, it's not, isn't what happened. I certainly would have done that for my own wife if I thought it was going to cause her to lose teeth.
It's beautiful. And it's something that I would like to ask that, but you already answered that. So for adults, you expand, and people said it's just tipped in. It's not expanding, isn't it?
There, you get skeletal expansion of the maxilla, and you'll get some bodily movement,
Mhm,
but you'll get some tipping,
mhm,
and the teeth won't fit like you and I were taught were to fit. But in reality, when you really go down and look for the science about occlusion that we have in what we were taught in dental school, is there a science regarding cuspid guided occlusion and incisal guidance and all of this? And what I'm going to say to someone who says there is, please show me those articles in the refereed literature with the double-blinded studies showing the benefit, some benefit. They don't exist. As a matter of fact, you know, there are a lot of people who say their practice is evidence-based. That's the greatest joke on planet Earth. Nobody has an evidence-based practice. I don't, you don't, no one does. As a matter of fact, I have a quote in the literature from an academic person who says approximately 8% of what is done in dentistry is truly evidence-based. 8%.
Okay.
So, I mean, these are great discussion points to have, but many of the prevailing things that we were taught have never been tested. And what I've done, I tell people I've made a living doing things that I was told I couldn't or shouldn't do.
Well, from my experience in regarding to my family, my friend who have teeth removed and how they have sleep problem, and I just look at your lecture, and it just makes sense. It just makes sense that when everything when God create a person with enough amount of teeth, and now you're trying to change God work.
Exactly.
uh,
Exactly. Very easy to understand. I came up with this analogy years ago. Everyone has a size 32 tongue. God gives you 16 upper teeth, 16 lower teeth like this. Because most of us have in industrial societies, and all industrial societies, really, we have poor rest oral posture. Our faces have fallen back, just like Dr. Daniel Lieberman from Harvard, the anthropologist, says, our faces are back. So we end up with third molars that don't have room. So before kids go off to college now, they almost all have their third molars taken out. Many of them will have had crowded teeth. They have low rest tongue posture. The maxilla caves in. They have crowded teeth, and the orthodontists have been taught to say, well, you got your daddy's teeth and your mommy's jaw. We have to take out teeth. So now we take out 4 bicuspids. So what you have is a size 32 tongue and a size 24 space. So figure out how well that works, because there is no evidence whatsoever that the tongue will get smaller. As a matter of fact, let's even take it a little bit further. For those who are familiar with Cruzon syndrome, Cruzon syndrome is a genetically determined syndrome whereby the sutures of the cranium fuse very early after birth. And what happens is the cranium doesn't really develop normally. The eyes continue to grow, the soft tissue grows, and the eyes bug out like a frog. So their eyes are prominent, and they get to the point where the eyelids won't even close over the eye. And so if they don't do something, the child will go blind. Of course, these people have tongues that don't fit in their mouth either. So they do. There's been surgery to change this for the Cruzon patient. It involves taking the top of the head off and taking the frontal lobe of the brain back, going in and advancing the whole orbits, the parts of the sphenoid bone, and go in from the inside of the mouth. It's like a 15-hour surgery. Several different surgical expertise surgeons have to be used, and they bring it all forward. And then the sutures will fuse. All this will fuse again, and the whole thing may have to be done again after the child has gone through adolescence. The point being that the soft tissue continues to grow even though the hard tissue does not. My analogy being that just because someone has 4 teeth taken out, does that mean that the tongue is going to get smaller and not get bigger? I have no reason to believe that. And I think the tongue is genetically programmed to grow the way it's going to grow. And when you make the garage for the tongue smaller, you're not doing anybody any favors. As a matter of fact, This morning in this consultation that I had with this 33-year-old gentleman, I said, so what is your chief concern? He says, my chief complaint is I can't speak normally. My tongue is in my way, and I cannot speak. Like, friends, if we're in a business meeting and I start talking, it's hard for me to talk. And he says, and I start gasping for air in the process. And I see other people are not doing that. So it just further confirms what common sense would have you believe.
Oh, it's wonderful. It's what a story, because I know in your website, your social media, there's a lot of testimony from adult patients who have 4 bicuspid taken out, and they have migraine headache, constant migraine headache, and they have all the symptoms. And after they get treated, the pain go away. It's something that only if we experience the case, then we know. You help the patient. Otherwise, people don't get it. Can you talk a little bit more about some of the story that you have with the?
Thank you for bringing that up. And every one of the patients we've interviewed, I don't interview them at all. I have someone else who does that, who gets them to speak their mind. And I want you to know also that I don't ever, when I'm treating these kind of patients, and I treat many what I call train wreck patients, people who've seen a zillion people and are ready to commit suicide. And I'm not joking. There are plenty of them who are ready to end it all. If you've looked for 20 years for a way to get rid of your pain and you can't find a way, then what are you going to do? So when I have conversations with them, I never say, oh, gee, tell me all the good things that are happening now that I'm treating you. That's a leading question. That's ridiculous. I call everything and, oh, by the way, Dr. Heng, comment when they come in and say, oh, by the way, I don't fall off the treadmill anymore now that you've done this. Gee, I haven't had any sinus infections, and I used to get 3 or 4 a year. Oh, by the way, the numbness in my hands and feet is gone, and that it was there. Oh, by the way, I never thought I had real pain, but now that you've reopened my spaces, the neck pain I've had for 20 years is gone. Oh, by the way, Dr. Heng, this is from a professional singer. I got my high range back after you reopened my spaces. These are the kinds of comments. But let me just share with you a story about a Japanese American woman who is very small, probably weighs 90 pounds, soaking wet. And she's in her 50s. And she came to see me after many years. She'd had 4 bicuspid teeth taken out. And she was a health nut, exercising probably 5 hours a day, doing yoga and everything else in the world to try to be healthier. And she'd been in treatment with someone to try to reopen her extraction spaces. And they used a certain appliance that I will not name, spent 3.5 years, and got about 3 millimeters of opening, which if I wanted to open her extraction spaces up and get a 7 millimeter space, I would have those spaces open between the crowns of the teeth in 5 months.
Wow.
It'd take me longer than that to get the roots apart so I can place implants, but I'd have that done in 5 months because that's part of my protocol. So she came to me and shared all this. And I said, well, I think we can help you. Never promise anything. After we did the treatment, and I'll get into the treatment, she said to me, you were the only one. I had seen more than 100 doctors before I saw you, and you were the only one who knew what was going on. I said, really? Well, what did you tell? What did I say to you? She said, well, I said I couldn't swallow, and you said, oh, it's probably your airway. And no one had ever even said anything about it. And so I reopened spaces in the maxilla only for her, and I thought she was a surgical case. And I told her so. And she got into treatment with me. And she started the treatment and she got better. And within a few months, she was dramatically better, feeling better already, just with me reopening the spaces. But she didn't get where she wanted to be. And so I said, okay, fine. We told you should do surgery. So she decided to do that. Interestingly, the story is very nice because she said, I'm going to have the best Thanksgiving of my life. Her surgery was scheduled just before Thanksgiving. She says, I'm going to be able to breathe. So she went to St. Louis, where my surgeon is that I work with, and had the surgery done. And 4 days later, she sends me a text message from St. Louis, a picture she'd taken with her cell phone. She'd gone out 4 days after surgery. She'd gone out for a walk in the morning, and she picked up some little stones that were in a rock garden, put them on the sidewalk, and spelled out the words, "I breathe."
Wow.
Took a picture of it, and she sent me a note and the surgeon thanking God, thanking me, thanking him, because she could breathe. And she said these were her words, not mine. "I don't have to suck air in anymore. I can breathe easily." She came back, and within no time, she was talking about many, many symptoms that were going away, including the fact that she had numbness in her feet that were going away, and she had digestive problems that were going away that she'd had for years. And she even said, I can do better fingering on my guitar than I did before, faster and better. And she said, my nickname that my aunt gave me was Squeaky. They called me Squeaky because of my voice. And she said, I'm not squeaky anymore. But the big thing was, she was sitting in my clinic chair one day, probably a year and a half after this surgery. And out of the blue, she says, Dr. Hang, I would do this surgery 10 times to feel the way I do today.
Wow. And
I'm very humble when I'm able to have such nice people like this that become part of my family and allow me the privilege of helping them. I make no promises to anyone. And I'm not here to say that I have all the answers, because believe me, I do not have all the answers. Not every case is a home run in the upper deck with the bases loaded. Sad part is we can sometimes do everything possible we know how to do to optimize the airway and still fall short. And I have done that.
Mm-hmm.
And so what it teaches me is that we cannot allow the face to fall so down and far down and back that even with the limits of surgery, we can't help these people. It also is appropriate for us to discuss the fact that it isn't all just about structure. It has to do with muscle tonicity and diet issues too, which have to be looked at.
Mm-hmm.
So in reality, we need to understand that we're really in our infancy in understanding all of these issues. We need to do further research, but we don't even know the right questions to ask yet. And we certainly don't have all the answers. But from my perspective, it's a wonderful time to practice dentistry, because the American Dental Association has told us this is our arena. We're mandated to be screening for this. Now, that just means to me, well, let's figure out how we're going to do this and help people, because that's really what it's all about. We are the stewards of the airway and facial development. And from my perspective, unless and until you get that nasal breathing, no one's ever going to be healthy. And for those who don't believe that, go read Breath by James Nestor. I just mentioned it a few minutes ago. It's an unbelievable book. Everybody needs to read Breath.
Brett, how do you spell the last name?
James Nestor, Nestor.
Okay.
He's a journalist from San Francisco.
Okay.
He describes what he's done. It's very interesting what he's done. Back in the 60s, Eagle Harville plugged the nose of monkeys and documented what happened to their faces and the way their faces grew when they were made from nasal breathers into mouth breathers. And what James Nestor did, he and another guy did this exact same thing. They plugged their noses and went from being nasal breathers to mouth breathers. And they did testing on themselves, medical testing, physiological testing, heart rate variability, and all kinds of stuff, blood pressure, everything, for I think it was a couple of weeks. And that changed their physiology instantly, and not for the better. And then once they took the plugs out, became nasal breathers again, everything fortunately normalized for them. But the story is very compelling. You got to read it. I'm not doing justice to it.
Thank you so much. Thank you so much. I really appreciate. Just one couple quick questions, like regarding to the terminology, bilateral maxillary protrusis. You mentioned in your talk that let's say, how would you treat those cases? Would you you're not going to take any more teeth out with those cases?
Right. But what the term that is used in the profession, an old term, is called bimaxillary protrusion, meaning that the face is too full. Of course, it's a stupid term, bi meaning two, and maxilla meaning maxilla. Well, we only got one maxilla. People have now called it bialveolar protrusion. But in reality, it rarely truly exists in nature. When you understand that if you're drawing a line from the nose to the chin, and that it's routinely done and the chin is very recessed, of course the lips are going to be full. It's an apparent protrusion. It's not true. Okay. And if the chin were forward, the lips would generally not be that far forward, except in certain ethnicities. Like I'm saying, the Asian population is going to have a fuller face because the nose is shorter. And from my perspective, you're not going to change the spots on a leopard. Don't mess with that. And I've had Asian people who are all concerned about that. Oh, I gotta flatten my face. No, you don't. Are you willing to die for it?
Also, I see that when you have bicuspid extraction, for Asian, you tend to have a periodontal problem because when you protrude so much, depend on how they protrude, how they retract it, they cause in a lot of perio,
It's interesting that you say that because, one of the reasons that we're taught in orthodontics to take out teeth is, number one, it's more stable. Well, that's a silly argument. Nothing's stable. And the University of Washington studies from the University of Washington Orthodontic Department show that 20 years post-treatment, 10% of the patients who had orthodontic treatment have, quote, acceptable alignment of their teeth. That's a pretty sordid record, really, when you look at it. And there's really no difference between extraction versus not extraction. So I'm unaware of one study that shows that straight lower incisors are going to stay straight just because you take out 4 teeth. My experience is that they're less likely to stay straight. Number two is that, if you don't take out teeth, you're going to get recession. So you have to get the teeth retracted, quote, over basal bone. There are 7 articles in the refereed literature talking about how you can advance the teeth and not cause recession. I've added extra bicuspid teeth in people who are not missing any teeth. I've even done that in a number of people, including a dentist, including a lawyer, where if you do something wrong on a lawyer, that's a bad deal.
Yes.
So I've added 4 extra teeth, and in the lawyer's case, I got rid of her sleep apnea and her headache pattern by so doing, making no claims that I would ever be successful in doing anything for her. Point is, she doesn't have any more recession than anyone else. So these are things that we've been taught, and yet they're not based in science, and we need to understand that. I have records on one case where all of the bicuspids have been removed in both arches, and you have permanent cuspids in contact with the first permanent molars. That's pretty crazy. Yet there's still recession on the lower anterior teeth. The idea is we need to retract and bring the teeth back to get them upright over basal bone to avoid recession. Then clearly there's more to it than meets the eye, and we've missed something along the way. So all of these arguments are things that if you're an orthodontic resident, you don't ask that question, you just accept it. But when you get out in real practice and you start to look at people, and as a general dentist, you can see the people in their 40s, you see what's going on for them. You're the one, you know more about this than I do. Yes. You're the one who's trying to treat them. You're the ones who are dealing with the periodontal problems, not me.
Dr. Hang, I want to just say thank you so much for really 50 minutes conversation. Dr. Hang, how can we reach out to you and take your course, or even the specialists want to take your course? What are your seminar in the next 6 months from now?
Okay, I have two mentorships which I do. One is called the ECHO, ECHO, Early Childhood Health Centered Orthodontics, and it's a year-long mentorship. We started our first one in May in Dallas, Texas, and we're going to have the second session of it in New Orleans later this year. And we have 2 3-day sessions with that, which are full-day lectures with some hands-on about how for those who have no orthodontic experience, how to do that, some bands and brackets and wires and stuff. Then we have an hour-and-a-half long webinar in the months where we do not have meetings. So we just had this week, for instance, on Wednesday, we had an hour-and-a-half webinar on that very issue. And we're talking about treating age 10 and under with a focus on treating in the primary dentition. That's the focus of this. And we're going to start another mentorship another year, starting probably in late April of next year. We'll have the second group. And then I'm going to be combining these groups. Then the other thing that we do is treating patients age 10 and older. And that's the ERRS mentorship. ERRS stands for extraction, retraction, regret syndrome. This is a syndrome that I've identified. I identify it as a constellation of aesthetic, functional, and emotional signs and symptoms brought on by orthodontic retraction, all of which is preventable. And again, I want to emphasize, I'm not saying that everyone who gets retracted is going to have this problem, but believe me, plenty who are retracted have these issues. And I have people contacting me from all over the world saying, I am an ERRS poster child. Everything that you said in your lecture, that's me. How can I get help? So I'm trying to train people to do this kind of treatment. And that's what that mentorship is all about. We have an active group right now that meets, and we have webinars every one Wednesday a month, and we have a spring and a fall in-person session for those groups. And I have information on how to do that, how you get to be part of it. For that one, you really need to have some orthodontic background, because you need that expertise. In the echo group, we already have something planned in this part of it to help teach the technical expertise of it. But if you contact me at hang@facefocus.com or Ortho2Health, ORTHO, 2 as in oxygen, Ortho2Health.com is where we have information on these two courses. And basically you can call my office and we're happy to discuss this with you. But more than anything, go to the website and you'll learn more about the details for these things.
What an honor to have you on my podcast, Dr. Wilhang. I really appreciate your time today, and I would love to be one of your students. So okay. I hope to reach out to you soon.
Okay, so nice for you to take the time to have me. I want to thank you for the opportunity to do that.
Thank you so much, sir. You have a wonderful Friday.
Okay, you do too. Bye now.
Yeah, bye-bye.